I think traditionally, when your patients come into your practice, you perform whichever tests you feel are necessary. So if the patient is coming for spectacles, then you perform a refraction. And I think this concept is going a little bit, and you have to move forward and complete what we call a full eye examination, which includes a refraction, but also an ocular health check. And the ocular health check, you can split it into the anterior parts and the posterior parts. The theme of this Congress, of course, is anterior eye. And so what I'm going to talk about are some of the things that we will see on the anterior eye pathologies, and especially what we call differential diagnosis. So how to tell one thing from another. So when a patient presents with some problems, how can you see that it's this or something else? And this is very important when we come to referring our patients to our medical colleagues. So when we think of the classic definitions of anterior eye and posterior eye, the anterior eye is everything in front of the iris. So the posterior eye, you can think of the lens, glaucoma and retina. The anterior eye will be the cornea and anterior chamber, the lids, the lashes, the conjunctiva. And one of the things I was always taught is when a patient walks into your practice, look at the patient very carefully when they walk in. How do they walk into your practice? And are there any things from their eye which are quite obvious and quite visible? And things like ectropion and when the eyelashes are turning out are quite obvious to see. And this is quite normal in older patients, but also can be related to disease and also the symptoms of dry eye. And entropion, when the eyelashes are bent inwards and they're scratching the cornea, these patients will have symptoms of pain in the cornea. They will have red eye, maybe even reduced vision as well. And again, this can be common with older patients. I used to see a patient who was maybe in her 80s, and she had entropion, but also had arthritis in her fingers. So every month she came to the practice, and I used to take out some eyelashes so that they wouldn't scratch her cornea. When we talk about blepharitis, this can be chronic, it can be a very common problem. Usually it starts in childhood, and it's usually associated with hygiene and irritation and infections. And we can separate it into anterior blepharitis and posterior blepharitis. The anterior blepharitis is more the bacterial types, and very common in patients with dry eye and eczema. So again, look at their skin and you will see the red, scaly pictures on their eyelid margins. And also links to styes. And I know that here we call a stye a hordeolum as well, but the hordeolum we're talking about here is external hordeolum, the outside one. When we talk about posterior blepharitis, this is a dysfunction of the meibomian glands. So we have a blockage in the meibomian glands, and this is quite common with patients who have some skin irritation and usually some sort of oily skin irritation. So acne or sebaceous dermatitis. And you will see oil droplets in their lid margins. And often you get oil accumulation at the meibomian orifices, at the openings of the meibomian glands. The tarsal plates look distorted and they don't look regular and smooth. So again, on a slit lamp, when you look at the tear meniscus, you should not just be looking at the tear height, but the regularity of the meniscus. So is it nice and regular, even all the way across? Is it distorted all the way across? Is it broken, etc.? And you will also see things like foamy tears, sort of bubbles in their tears. So this is the more posterior blepharitis. You can see the oily droplets at the meibomian gland orifices. And in this case, it's caused this posterior hordeolum, which is kind of like a stye, but not exactly the same. So how do we treat these blepharitis patients? Well, you need to keep their eyelids clean. And we used to say that you can use baby shampoo and things like this, although now we think that's not such a great idea because baby shampoo is a surfactant and it's a soap, so it can also break up the tears. So maybe we should use these specialized cleaning agents that we can buy from our pharmacy friends, lid scrubs and lid hygiene pads, and specific solutions for this. In more serious cases, especially anterior blepharitis, when it's bacterial, then we need to use antibiotic ointments. And in severe cases, when it's starting to affect the cornea, you may also need to give the patient some topical steroids. And this is where our medical colleagues would help us. Now, I mentioned already styes. Let's think of the external hordeolums, and these are blockage in the Zeiss or mole glands. And these are quite tender. When you touch them, the patient doesn't like that because it's a little bit painful. And often there's a eyelash is associated with the cyst as well. And it's quite a large cyst, and you need to have some sort of surgical intervention to break this. Internal hordeolums, which are more associated with the meibomian glands, very similar to the stye, but usually more painful. And they can be pointed as well, so that the shape of the internal hordeolum is triangular, and sometimes they point inwards. And if they point inwards, then this can affect the cornea as well and can distort the cornea. And very closely linked to this is a meibomian cyst or a chalazion. And again, this is to do with the gland dysfunction. Our expert in the room on chalazion is actually our translator, who had 5 of these. Eyelid tumors. So these are more serious, of course, and you need to be able to tell an eyelid tumor from a chalazion. Now, both of them will have some sort of growth, but in an eyelid tumor, the growth is usually rapidly progressing. There may be some change in coloration. There may be some vascular changes as well. And the most common type of eyelid tumor is what we call a basal cell carcinoma or bacilloma. Also, a type is called rodent ulcer, and this actually looks like a mouse has bitten the skin, and it's like a scratch, a vertical scratch. We can have these skin type of tumors, which is like a squamous cell carcinoma, again, very fast progressing, and these usually ulcerate. So the top of these usually becomes flatter and starts to bleed. And then very occasionally you can have a sebaceous gland carcinoma, and these look a little bit like chalazion, but again, what you need to look for is when you evert the lid, to look for the vascularization and maybe discoloration there. Now, again, if we start from the front of the eye and work inwards, then looking at your patient, we should look at their eyelids as well. And litosis is quite common. And if you look at your colleagues next to you, even a small amount of litosis is quite common even in normal patients. So it's not just in aging patients or disease, but it's very common to see litosis, especially after some sort of eye surgery. So usually there's some third nerve palsy type involvement, so there's some paralysis of the levator muscle. So one of the types is what we call neurogenic. So this is affecting the nerve. The aponeurosis, which is this large muscle here. The myogenic, which is dystrophy of the levator, and a mechanical one. The mechanical one is linked to surgery or scarring or some other, maybe trachoma or something like this. You can have almost the opposite of this, where the eye looks quite large, and we call this exophthalmos, where the eye bulges forward slightly. And this is usually an excess of orbital fat pushing the globe forward slightly. And when you have this, the lids are slightly retracted, they're pulled back, and the patient can't blink fully. And so when they try to blink, often they have a dry patch in what we call the 3 and 9 o'clock positions. So this is quite easy to see this kind of 3 and 9 o'clock staining. And also in this child picture, you can see that one of her eyes is much larger than the other, or appears to be larger because it's been pushed forward. And we call this proptosis. Again, from a differential diagnosis, we want to make sure that what we're not seeing is an orbital tumor. Is there a growth inside the orbit, around the orbital fat? Is there some sort of extracellular debris which is growing and causing a problem? And of course, you can't investigate that area yourself, so maybe this is where we would need some sort of MRI scan or something like this. And you can see this picture here on your right. This is a hemangioma. At first glance, you might start to think this is a chalazion. You might start to think it's a sty. You might think it's a hordeolum. One of the things it hasn't got is there's no orifice problem. There's no on the meibomian glands, and it's not pointed. It's quite a large, circular type of cyst. Lymphomas you can get in pretty much any part of the eye, and I'll show you an X-ray in the next picture. And there are other types of tumours. We don't have to list them all. But this is a lymphoma. You can see here it's pushing behind the globe, and it's pushing the orbit forward. So again, this patient will have an appearance where their eye has an exophthalmos appearance, and it looks like their eye has been bulged forward and pushed forward. This one here has a lid swelling as well, which again you might think is related to something else, but again you should watch these patients. Especially beware of a patient who presents for the first time with something like this and says, oh, I haven't noticed it, or no one's noticed it, but now it's growing. Maybe there's no pain initially. Let's turn our attention to the conjunctiva. And remember, the conjunctiva is essentially like a sac. So we have this superior conjunctival sac and an inferior conjunctival sac. And one of the most common conditions that we will see from our patients is bacterial conjunctivitis. And these patients will present with a gritty sensation. Their eyes are in pain, but it's like a very irritable pain. It's itchy sort of pain. They will have redness in their eyes, and often they will have sticky eyelids as well, because bacterial conjunctivitis means the source of the problem is bacteria. And so they have this sort of what we call a mucopurulent discharge. It's a very sticky, yellowy discharge, and the problem is usually worse in the fornix. So when you lower the lids and lift the upper lid, you will see the redness is much worse in the superior and inferior fornix. The vision for these patients is usually normal, the cornea is normal, and the pupil is not distorted. So here you can see that there's a lot of injection. You can see it's worse in the fornix, and this is a typical sort of bacterial conjunctivitis. And this is what we mean by, this is quite a severe, both are severe cases, but this is what we mean by that mucopurulent discharge. It's a very sticky, yellowy discharge. And another type of discharge you might see in patients is when they have allergic conjunctivitis and they wake up in the morning, maybe they have an allergy to pollen in the flowers, and they have a discharge and they pull their discharge like this, and it's very stringy. It's a yellow stringy discharge. This is a different type of discharge. This one is very sort of like a Vaseline petroleum jelly type of discharge. Viral conjunctivitis is usually bilateral. When they present to you, it will be bilateral because it spreads very quickly. And the type of discharge you will see is very watery. So you don't get this sticky, jelly-type discharge. You don't get a stringy discharge. It's a very watery discharge. When you invert the lids, the conjunctiva doesn't look pointed. It looks follicular. So there's quite large lumps and quite flattened areas. They may also get some hemorrhages. You may see some subconjunctival hemorrhages, and also they often develop some corneal staining, some punctate keratitis. You may also see some stromal infiltrates as well in these patients. Now this is a typical, what we call adenovirus. This is a very common viral infection, and if you have a patient with this type of viral infection, by the time they come into your clinic, usually it's in both eyes. And you need to be careful that you don't spread the infection yourself, because you can spread it to yourself, you can spread it to other patients, so you need to clean the area that you're using with some disinfectant wipes. And also tell the patient that it can spread very easily to other people in their house. It can spread to their children, their wife, their husband. So they need to make sure that they don't use the same towel as their partners or their family. So it spreads very quickly. And this is what we mean by that follicular conjunctivitis. It's not a pointed conjunctival response. It's a sort of a flattened but large, rounded bumps. Now, we don't really see trachoma in Europe. With migration from Africa, you might see some African migrants with this type of problem. It used to be the case in the 1970s, if you wanted to move to Australia, one of the checks for your eye disease was trachoma. They used to check that you didn't have trachoma. And it's a large cause of blindness in poor countries. And it's a bug that's carried by a fly, common fly. And you see this follicular reaction in the upper lids. And these patients can become blind through scarring of their conjunctiva and cornea. And you would typically treat this with tetracycline, but like I say, it's very, very rare to see this in European patients. Now, vernal conjunctivitis, like pollen, allergic type conjunctivitis, we start to see what we call spring catarrh and these papillae again. So this is a type of giant papillary conjunctivitis. And giant papillary conjunctivitis isn't just from pollen. It can be allergies to perfumes. It can be allergies to contact lens solutions. It can also be contact lens related. So sometimes patients have a giant papillary conjunctivitis caused by deposits on the contact lens or even the mechanical irritation of the contact lens. And the everted lids, when you see the conjunctiva, you start to see these points in the conjunctiva. These patients will be photophobic, they have itchy eyes, they have this stringy discharge that I was talking about, so they can, in the morning they say, I do this to my eye and I pull out this yellow string. And often they will need some sort of steroids or opticrom, some mast cell stabilizers. And not the steroids, but the other medications, a lot of these are available over the counter by our pharmacists. Now, as the sclera gets older, it becomes more rigid. We have changes in the collagen and the elastin, and we see this yellowing of the sclera. And overall, from a child to an elderly patient, we have a change from blue sort of conjunctiva to a white to a yellow one as we get older, as the sclera changes its color. And in our older patients, you also sometimes see what we call scleral plaques. And these are patches of scleral translucency, where the sclera is very thin and the choroid is showing through. And usually they're oval in shape, they're quite small areas, and they can also be caused by depositation of calcium sulfate. So linked to these, we can get infections in the sclera. Again, one of the common ones is what we call episcleritis. And episcleritis is an infection, bacterial infection, in the overlying conjunctiva. And this is as opposed to scleritis, which is a more deeper infection. Now, episcleritis is in the outer part, and you can tell this by when you move the conjunctiva with your finger from the outside, the blood vessels move. When it's a scleritis and it's deeper, and you move the outer conjunctiva, the blood vessels don't move because they're much deeper. The redness is much deeper in the sclera. So episcleritis is quite common. It's quite a mild infection. In mild cases, we might not even treat it. Maybe in more advanced cases, we might give some steroids, some antibiotics, etc. But scleritis is much more serious. And scleritis is more painful. It's much less common. But it's usually associated with some systemic problems. So it's usually associated with some type of Crohn's disease or spondylitis or herpes or something gout, some sort of immune response. It's some autoimmune disease. And the type of pain that the patients will report is not a sharp pain. Remember that sharp pains are usually from the cornea. So the type of pain the patient will have here is quite a deep pain. They will report this sort of what we call an aching pain, almost like a headache pain in their eyes. So they get this sort of quite dull pain, quite continuous. And it's all the time. Now, sometimes you have a patient that'll say that I have this dull, aching pain when I move my eyes. That's more related to a muscular problem. Or some patients, they report this dull, achy pain at the back of their eyes, which could be linked to an optic neuritis. But here we're talking about this dull, aching pain constantly. So this is just some examples of scleritis, and this is what we call a non-necrotizing scleritis, which basically means the tissue is still alive. In this picture on the right, the scleritis is starting to die. It's what we call a necrotizing scleritis. Scleromalacia perforans is malacia and illness of the sclera which can perforate through. And you will see this with patients who have long-term systemic problems such as rheumatoid arthritis. And there's a very thin area of sclera, and the underlying choroid is starting to show through. It's very, very rare for it to perforate. It can happen, but it's extremely rare. And perforation is only likely to happen if there's dull trauma to the eye as well. Usually you wouldn't get that, especially because this is more with elderly patients. Okay, let's move on to the cornea. So, remember the corneal structure is essentially 5 layers. We have epithelium, Bowman's membrane, stroma, Descemet's membrane, and endothelium. And the epithelium is about 5 or 6 cell layers in thickness. And remember that the epithelial layer regenerates all the time. So the basement membrane, the basal lamina of the epithelium, generates new cells. So the new cells are at the bottom of the epithelium. And then as they get older, they move forward. And they start their life in a column sort of pattern. They have this what we call columnar cells. And then as they get a little bit older, they move up and they become these polyhedral cells. And then as they get older, they move up and they become these flatter cells, what we call squamous cells. And on top of the outer epithelial cells is, of course, the tear film. And the outer epithelial cells have these very small, what we call microvilli, very small points on them, which helps to keep the mucin of the tears locked onto the surface. And when you put a contact lens on the surface, you break some of those microvilli. So you will induce some dry eye problems just by putting a contact lens on your patient. So just remember what's happening to the epithelium, what's happening to the cornea when there's a disease, or even when you're just putting a contact lens on the eye. Now the next layer down is the Bowman's membrane. And the Bowman's membrane is essentially a very thin connective tissue membrane which is there for strength and stability. Underneath the Bowman's membrane we have the stroma. And the stroma is this very regular lattice pattern. And it has to be a very regular pattern, because if it isn't, it wouldn't be transparent. So if there's a change in hydration in the stroma, or there is some trauma that affects the stroma, then you can alter the structure of this regular lattice pattern. And if you do that, if you affect the regular lattice pattern, you will get a scar. So usually, when a foreign body comes onto the eye, like a small piece of dust or a piece of sand or a little insect flying onto the surface, it affects the epithelium. And then it breaks away and falls away, and the epithelium regenerates. If the foreign body breaks through the Bowman's membrane, it has to be sharp, it has to be fast, but then it can affect the stroma, and then it will affect the hydration, and then it can cause a scar. So when you see a corneal scar from a foreign body, it means that it must have penetrated through the Bowman's membrane. So the type of people who have this sort of injury would be like a mechanic working under a car, and he's with bits of metal and something flies and hits his eye, and this type of fast metal projectile can penetrate through the Bowman's membrane. So at the lower end of the cornea we have the Descemet's membrane, which is the elastin-based membrane, which is there essentially for the strength of the cornea. And then we have this single cell layer called endothelium. And the endothelium is actually one of the most important layers because it keeps the cornea alive. It helps the salt pump going in and out of the cornea, and we want to protect the endothelium. So really, when we have penetrating injuries, it doesn't really go as far as endothelium. So, most corneal surgery wouldn't even go as far as endothelium. It's quite a protected layer. But the endothelial cells don't regenerate with life. So as we get older, we actually lose cells. So our endothelial cell count goes down. Epithelial cells regenerate all the time, endothelial cells don't. So again, think about contact lenses. With a contact lens patient, we want to make sure the endothelium is healthy, so we want to make sure that our patient has a lens with a good decay, a good transmission of oxygen going through, so the endothelium isn't starved and doesn't become hypoxic and doesn't become what we call polymegathism or polymorphism. It changes its shape, changes its density. And especially in younger contact lens patients, they want to keep their corneal cells, endothelial cells alive for many, many years. So, as I've said, with a foreign body injury, usually the foreign bodies are in the epithelium, but if they go beyond the epithelium, they can cause stromal scarring. And sometimes you can see a metal, what we call a rust ring. So metal foreign bodies hit the cornea, and sometimes the metal foreign body is gone, it's fallen away, but it leaves an oxidized brown ring in the stroma. And remember that a penetrating foreign body can actually go right through the cornea and into the globe. So you can actually get a foreign body that breaks all the way through. Photokeratitis is essentially a corneal infection or a keratitis linked to light, and mainly UV light. And what's interesting here is the patient will get what we call foreign body sensation. Although the problem is caused by light, it feels like something's in the eye. So they get foreign body sensation, they get photophobia, lacrimation, blepharospasm, they can't open their eyelids. They usually get reduced vision, they will get redness, hyperemia. But the important differential diagnosis is there's a latency period. So, for example, if your mechanic was working on his car and a metal foreign body entered his eye, he will report immediate pain. If the problem was he was welding some metal on the car and the photokeratitis occurred, there is a latency period. So usually 6 to 12 hours later, they will think that something's gone into their eye. And they come to your clinic and they'll say that, I feel like something is in my eye. And you'll say, what happened? And they say, well, this morning I was working on my car, I was welding some metal together. So you can understand it's a photokeratitis. If it was a foreign body, it would be an immediate pain. And sometimes you see patients and they say to you that they had photokeratitis related to welding many years ago, and sometimes you see a stromal scar in these patients as well. And remember, the cornea has an increased sensitivity to UV light. So, for example, if you go to the beach and you lie on the beach to get some suntan, on the first day you can lie for 1 hour. The second day you lie for 2 hours. Third day, 3 hours. Because your skin has an increased tolerance to UV light. Every day you can have more UV light on your skin. The cornea is the opposite. So if you have an exposure of UV light on the cornea, photokeratitis, the next time you're exposed to the UV light, you actually need less dosage of UV before your problem occurs. So the eye has a increased sensitivity or decreased tolerance to UV light. So you need to warn these patients who had photokeratitis in the past. They should wear goggles, they should wear a mask when they're welding, when they're using this welder's flash torch to fix metal and things like this, that they need this protective goggles. And on these patients, you often see punctate keratitis. You see this sort of, when you put fluorescein in, you see little spots of staining. It looks a little bit like dry eye, but it's related to the photokeratitis. Bacterial keratitis is a type of infection caused by bacteria. And remember that your eye has its normal protective system. It has tears which wash away the debris. It has quite a strong cornea which can make sure nothing gets through. And epithelial cells which regenerate. But if something's happening to the eye, such as corneal abrasion, maybe that's from contact lenses, maybe it's from entropion scratching the lashes, scratching the cornea, maybe it's from dry eye, maybe it's steroid use. So something's happening which has weakened the cornea, then the bacteria can get in. And common infections, staphylococcus, streptococcus, and they can be quite common after somebody's had a sore throat or a cold. And so when a patient has an eye problem, sometimes we will ask them, did you recently have a problem, a flu or a cold or a cough? And sometimes they have bacterial infection somewhere else that's now affected the eye. So this is a type of bacterial keratitis, and we were talking earlier on about bacterial conjunctivitis, and this is a sort of a link to that. In these patients, we probably will have pain, we have this redness, and maybe we'll have that sticky discharge that we talked about. This is a marginal keratitis, so it's affected now not just the conjunctiva and the cornea, but also the lids as well. And this is a Pseudomonas, an ulcer caused by Pseudomonas. Pseudomonas is a type of bacteria which will rapidly perforate through the cornea. So if you have suspicion of Pseudomonas, we need these patients to be treated quite quickly. There are other types of keratitis, fungal keratitis, which is very rare actually. But you might see this in farmers. Sometimes farmers work with animals or vegetation or crops, and they can pick up bugs or pick up fungus from those things, and they can touch their eyes. And I saw a case of a farmer who he picked up a fungus from the horn of a cow, and he touched his eye, and whatever fungus was on the cow went into his eye. And it's quite an obvious problem that they have. When you take the history, you can understand what happened. Viral conjunctivitis, linked to viral conjunctivitis, will have that watery type of discharge. It's highly contagious, highly infectious, and usually by the time they present in your clinic, it'll be bilateral. Herpes simplex and herpes zoster are less contagious, and herpes simplex is linked to this sort of people who have these problems with on the lips. Sometimes they have that, and often this sort of thing can affect the eye as well. And the herpes zoster is usually in older patients. So a herpes simplex virus has a very, very classic type of ulceration pattern, and we call it dendritic ulcer. And it looks like these little tree branches growing off. And if you leave that, it can form this sort of disky form. It can form this sort of larger type of keratitis. And this is now becoming a more deeper cut into a deeper abrasion into the cornea. The herpes zoster is usually associated with older patients and usually has some skin association as well. So usually this one you will see it quite obviously. When you look on the cornea, you'll see some ulceration, but certainly you will see some skin problems as well around the eyes. Now, again, when we talk to our colleagues who work in factories and industry, we warn them about hazards that might be in their workplace, such as the mechanic and metal and things like this, our dental colleagues using UV lights, but also people who work with chemicals, and if somebody works with acids or alkalis. And acid injuries can occur, of course, and acid or alkali injuries, whenever it happens, you need to wash out as quick as possible. Alkali injuries can be a little bit more progressive because the acid injuries have a sort of a self-limiting coagulation because of the surface epithelium, whereas alkali injuries can just carry on. So you need to have this wash out quite quickly. And it's quite common to get alkali injuries in builders, for example, because builders use cement and calcium carbonate is an alkali. And so if they're mixing cement, for example, so it doesn't have to be alkali liquid, it can be alkali powder. As they're mixing the cement with water, the dust can sometimes go onto their eye surface, and this can cause this alkali injury. Now this picture is of a very severe alkali burn, and I don't know if you can see what's happening here, but this where the mouse is now, that's the edge of the limbus. Oops. So this is the edge of the limbus here, and this central white area is the central portion of the cornea. So this cornea has pretty much been killed off. It's pretty much dead. And You couldn't even do a corneal graft on this cornea because of the vascularization. So you would have to try to treat some of the vascularization and maybe reduce the inflammation. And maybe you could do a transplant later. Or they could have one of these orthodontic keratoprostheses. Again, pterygium we see quite a lot, especially in warmer climates. And usually it's in the nasal side. Occasionally you'll see pterygium on the temporal side. If you see it on the temporal side, usually it's linked to injury. Usually it's a trauma. On the nasal side, this is more common. And again, it's more common in warmer climates, in African countries, for example. And you see this small grey opacity at the nasal limbus, and the conjunctiva grows over it. And it doesn't usually cause any problems, but the patients don't like the look of it. And occasionally it can cause a pull and cause astigmatism. And if it's getting worse, it can grow over to onto the cornea. And if it grows towards the pupil area, the central cornea, then we need to reduce it. We need to have some surgery to remove it. But usually it doesn't grow as far as the pupil. Usually it just stays at the limbus. The fictonucleosis is essentially when we get this nodule at the limbus, and again it can extend into the cornea and cause an ulceration. So other ones. So this is a pterygium. This is quite a severe pterygium. You can see here, in this case, it's grown towards the pupil area. So this one would need to be resected. The surgery would involve cutting here and removing the conjunctiva, but also trying to get rid of the grey nodule which caused the problem in the first place. Otherwise, it will regrow. There are other types of ulcerations we can see in the cornea, marginal ulcers, Moran's ulcers, and you can have ulcers associated with systemic conditions as well. And this is an ulceration in the peripheral cornea related to rheumatoid arthritis. There are various types of corneal dystrophies. Probably the most common ones that you will see will be endothelial dystrophies like Fuchs dystrophy. And, of course, what we call the primary corneal ectasias. And these would include keratoconus, keratoglobus, pellucid marginal degeneration. And you could see an ectasia post-surgery, so post-laser surgery, post-graft surgery, but those aren't primary, those are secondary ectasias. So this Fuchs endothelial dystrophy, you will see this granular sort of pattern, this misty pattern in the endothelium. And if it's affecting the vision, then you may need to have partial thickness corneal transplant in this patient. Keratoconus, I think we're probably quite familiar with. And so I only have a few slides on keratoconus, but it's a common problem. We have an increase in irregular astigmatism. The patient has worsening VA. And the VA, you can't correct it anymore with specs or regular contact lenses. So they now need gas permeable or special scleral or keratoconic fitting contact lenses. From a clinical point of view, we also see corneal thinning. We also see the cornea bulging forward. It's pushing forward. And you can see this on your keratometer and especially on a corneal topography machine. You also can see Munson sign, which is this pointing of, when the patient looks down, the eyelids look pointed. You can also see these Vokes stress lines. So remember that the cornea is bulging forward, it's pushing forward. So Vokes stress lines are these vertical lines in the cornea caused by that pushing forward. So it's like a stress mark. You can see this, what we call Fleischer's hemosiderin ring, which is a brown pigmentation in the cornea, in a line usually, but in keratoconus it becomes circular, so it turns upwards. And one of the most common things to say, and I think this is one of the most obvious things, is the corneal nerves look more prominent. Remember, the cornea is thinner, so the corneal nerves look bigger, they look whiter, because you can see them more clearly. And of course, keratoconus is associated with other systemic conditions like Down syndrome, Marfan syndrome, retinitis pigmentosa, and other conditions as well. So this is an example of those Vokes vertical stress lines. And this is that Munson sign again. Okay, let's move away from the cornea into the uvea. So the uvea is the vascular tunic of the eye, from the front to the back. And from the back it's the choroid, then in the middle it's the ciliary body, and then at the front it's the iris. So in terms of anterior eye problems, we're only going to talk about the iris today. So the iris is this curtain-like circular membrane, and an iritis is an infection or an inflammation of the iris. And we can have posterior iritis or anterior iritis. You can also have natural congenital defects in the iris, and this is an example here of what we call a coloboma. And a coloboma is an iris tunic which hasn't completely sealed. So there's a gap in the iris. And this patient might report to you some photophobia. They might get some reduced vision in this eye as they're getting older, because this eye might not have the same visual acuity as the other eye, so they may get some amblyopia. So if you see this in a child, then sometimes it's useful to maybe fit them with a contact lens that creates an artificial pupil. Occasionally you can see this type of iris defect from a surgical problem as well. We've mentioned injuries already, but it's worth thinking about injuries again in terms of the iris, because those high velocity projectiles that can perforate through the cornea can go through the iris. And I can give you one example. I had a friend who was a dentist, and he told me when he was training, one of his friends from dental school was working on a drill and drilling somebody's tooth, and something broke off the drill and hit his eye. And it went through his cornea, and it went through the iris as well. And on the cornea, you couldn't really see much because it perforated. But on the iris, what you could see is that there was a rip in the iris. So something had obviously gone through the iris. You can also get iris injuries through blunt trauma. And one of the most common things is, I don't know if you call it the same thing here, but what we call a bungee rope. A bungee rope is this elastic rope. And when you're fixing something to the top of your car, like a box or a suitcase, and you fix it to the car, you put this elastic rope around, and it has these metal hooks, and it hooks onto the bars of the roof of the car. And one of the common injuries is that somebody didn't hold the hook properly, and the hook flew and hit somebody in the eye, and this iris hook, this bungee hook hit the iris. And it can also cause traumatic cataract. So these patients can see traumatic cataract. You might see hyphema, so blood in the anterior chamber. But the common thing to look for is this iris dialysis. And this is what it looks like. So when they have this blunt injury or this perforating injury, you get this rip in the iris, and the iris has been ripped from its root and its anchoring position, and it's pulled away. And this is quite a severe iris dialysis in this case. And it's not very obvious in this picture, but you can just about make it out. Sometimes you can't really see exactly where the rip is, because it's a very small rip. But what happens to the pupil is the pupil starts to point towards. The pupil kind of points towards where the rip is. In this case that I was talking about the dentist, it was such a small rip you couldn't see it very clearly, but the iris distorted, and the point of the iris points to where the injury is, where the perforation has occurred. And anterior uveitis is the most common type of uveitis, and often we call it an iritis. You can say it's a iridocyclitis if it involves the ciliary bodies, but normally we're just talking about iritis. And in iritis, the patients will have photophobia, this light sensitivity. They'll have reflex lacrimation, reduced vision. But here, the differential diagnosis is around the floaters in the anterior chamber. Remember, the anterior chamber has this aqueous humor in it, this liquid, which is clear and transparent. And if you have some iritis or anterior uveitis, you'll get cellular debris in the anterior chamber. So when you look with your conical beam of your slit lamp, you see these cells, what we call flare. It's aqueous flare. They look like little stars. These patients would have pain, but it's going to be this deeper pain that we were talking about, not the sharp corneal pain. And this is an iritis infection. You can see in this case it's caused distortion of the iris as well, and possibly even synecdoche of the iris. What you will see, this hyperemia, this episcleral injection, constricted pupils often, but really look for the flare in the anterior chamber. That's the thing to look for, really. And sometimes you also see inflammatory cells in the anterior chamber, and sometimes you can also see inflammatory cells on the back of the corneal endothelium. So what we call keratic precipitates, so small cells on the back of the corneal endothelium. So these keratic precipitates are that aqueous flare, but cells that are sticking to the endothelium. Look for the pupil margins, as we said before. Look at the anterior surfaces. Look for dilated iris vessels, and also look for hypopion, which is this yellow pus. It's the white blood cells gathering in the anterior chamber. So this is what you see. You see a fluid level of this white blood cells in the anterior chamber. It's called hypopion. In more severe cases, in iritis, the iris may even stick to the lens because it's so inflamed that it's now sticking to the crystalline lens. We call this posterior synecdoche. If it's inflamed and it's sticking to the cornea, we call this anterior synecdoche. And when you get these types of synecdoche, one of the secondary problems could be that the drainage of the fluid isn't happening correctly. So these patients can develop glaucoma as a secondary response. So this is a secondary posterior synecdoche where the iris is sticking to the lens, and you can see the iris will be folded back, touching the lens. And glaucoma secondary glaucoma is the secondary complication that you might see in these patients. Sometimes they call it 30-day glaucoma because after 30 days or so they get this problem. Thank you very much. I finished at the limit of the anterior eye. I'm not going to talk about the lens or the posterior eye. I think there's enough information there to gather. I've added my email address here. If anybody wants a copy of the slides, I'm happy to email you the slides. You can have the slides, and if you want to email me any questions, you can do as well afterwards. Thank you very much.